Hi, folks. This is Dr. Rob Cyrus. I am the Carb Addiction Doc, and I've been looking forward to this discussion for a very long time. We have Dr. ANDREA SALCEDO with us. She's the conscious gynecologist, and she and I have been working in the ketogenic space for a very long time. I'm going to let Dr. Salcedo, I'm going to call you Andrea, just like I'm Rob. Um, Tell us who you are, what you're doing, how people can get hold of you, and what your special interests are, because today's discussion is going to be about female hormone replacement therapy. But give us your background.
Hi, thanks so much, Rob. So I'm Dr. Andrea Salcedo. I'm the conscious gynecologist. I'm a very specialized OBGYN because I have a huge interest in metabolic health and as it relates to obstetrics, but also gynecologic disease. And that just means that we look at the uterus and the ovaries as recipients of cardiovascular disease, just like any other organ. And so that means fibroids and endometriosis and heavy periods, irregular periods are all just manifestations of the same problems that you treat, that I treat on a daily basis. But I really feel bad for a lot of women because sometimes they just think it's like a female hormone problem of like, everything that they're going through. And a lot of docs will send them over to me to like fix their hormones, but it's never the hormones that we think of, estrogen and progesterone. Most of the time it's insulin resistance and chronic low-grade inflammation. And so that's what we do. I'm just trying to, shed light on this platform of how women's problems, women's gynecologic disease is really cardiovascular disease.
I appreciate that. And the two additional things I want to throw in there is, first of all, hablo español. And
Sí, sí, hablo español, sí.
that's my entirety of Spanish right there. But there are so many people that watch this video. For example, Chile is one of my largest audiences. And the beauty about what you do is you're comfortable, am I correct, in speaking Spanish as well as English. So people from all over the world can access you from outside of this country, and Spanish is something that you're very comfortable using as a medium. Is that correct?
Oh, yes, that's right. And I forgot to mention because I got excited about all my cardiovascular disease that I do have a full scope academic OBGYN practice. I work at Loma Linda University Health, and that's very traditional OBGYN. I do a lot of metabolic health there in California, but I also have an awesome telehealth practice that I develop for folks in California and Florida, but also all over the world who are just interested in looking at a consultation of something different, something that might not be on the traditional beaten path of how we manage gynecologic disease. So that's been a lot of fun. ConsciousGynecology.com is my website, and you can schedule an appointment that way.
And you can get
And
her
in inglés y
contact.
español.
Yeah, there you go. Okay, there you go. And in the show notes, you'll be able to get all of Andrea's, Dr. Salcedo's information, how to contact her, how to reach out to her. The other comment I just wanted to put out there that is such an important concept, and you mentioned that you do OB as well as GYN. One of the key things is managing both the woman and the fetus in utero metabolically. And I just came back from South Africa. They're running at close to an 80% gestational diabetes rate for their pregnant females, and it is abysmally managed. So if patients have gestational diabetes, if they want to improve metabolic health, if they want to improve brain development to their fetus, you have the ability to guide them very with a great degree of expertise in managing their diet in utero. Is that correct?
Oh, absolutely. And I know we're talking about hormones today, but this is a really important topic that I want to impress upon our viewers is that the first trimester, actually, even before the embryo implants, is actually the most important time in the pregnancy because not only is the conceptus implanting on the lining of the uterus, and if your body already has low grade inflammation, evidence of disease, then it's going to impair that connection. But the interesting thing about first trimester is that the fetus doesn't have a pancreas, okay? And so because it doesn't have a pancreas, it's relying on the biologic adaptation of morning sickness to keep those levels of glucose very low and steady. Okay, so that's a biologic adaptation. And so a lot of folks feel quite frustrated that they're not hungry during pregnancy or they have to eat for two. And that's really because your body's trying to protect itself from big slugs of glucose that can actually impair and cause a lot of inflammation to the developing fetus in that first trimester when all the organs are trying to develop. And so yeah, I mean, the concept of no pancreas in that first trimester is really important because pancreas is where insulin comes from, right? And so if you don't have a pancreas at that time, it really relies on mom to keep things steady.
Beautiful. I'm going to pump the brakes on that because I think you and I need to do, together with Janae, do a specific episode that is about fetal
Oh
growth,
yeah.
pregnancy, as well as how we feed our own kids and how parents can optimize the health of their children, which is opposite to all the recommendations right now. So that will be coming up. I think that's going to be a very
That's right.
important
That's
concept.
right.
But folks, everybody has something they enjoy doing. Some people love to pig out on pizza. Some people love to go to Vegas and gamble. Some people love to go to the gym and do sport. I do some of those things, but what I really love to do is to be out in the garden, isolated, doing yard work. And as you can tell by my nails, yesterday I was out in the garden working my ass off, literally from 6:30 in the morning till sundown at about 7 o'clock here. And here in Florida, it is humid, it is hot. And the two things that I do my Redmond Relight, but what I've also found is incredibly helpful to avoid, and obviously you've got to understand that the health consequences of this, but to avoid that headache, that dehydration, that lack of energy. I take these ketone IQs with me, and about every 4 to 6 hours, about 3 times yesterday, I took these ketone IQs. Right when I started out, as I was dragging, I stayed up with my hydration, my electrolytes. But as I was dragging, I hit a ketone IQ. I don't eat during the day when I'm out there. I don't need the energy in terms of nutrition, but I do need the energy in terms of my ketones and my fat. And this ketone IQ helped me yesterday to get through an entire day of digging holes and planting new plants. And it was pretty cool. And I came in, and usually I'm wiped out, exhausted. I'm sore and stiff, but I don't feel the usual hangover that I do after a long day like that. This ketone IQ stuff helped me through my day yesterday out in the yard. For today, let's jump into hormone replacement therapy, female hormone replacement therapy. And really, what I'd like to focus on, because there's so much to talk about, I want to focus on the transitional period in a woman's life where there's either a surgical or lifetime involution of the ovarian function. What that means is for me as a guy, I've got testosterone, I've got estrogen, I've got some progesterone, but my levels are fairly constant until I die, maybe dripping down a little bit. But for most females, they do a sudden crash, whether it's because of a loss of an organ, their ovaries or the uterus, or whether it is because of that time of their life, the perimenopausal time. That's the block of time that we're going to be talking about. And I think the way my own head works is I divide it up into two different sections, but I want to hear your comments on this. One is the sexual function, which we correlate with the female hormones, but someone like Georgia E, and we've known this for a long time, the majority of cells in your body express an estrogen receptor. Well, that's often got nothing to do with sexuality, but it has to do with cellular biologic function. And to my mind, HRT is as important, if not possibly more important, for global cellular function, brain function, all the other cells, as it is for gynecologic function. And all too often, gynecologists get trapped in the gynecologic side of things, but don't consider the overall human being. So that's just the pretext. So the first question for you is, when in a woman's lifespan do you begin to test for the possibility of hormone replacement therapy? At what stage, at what age, when do you begin those tests?
Well, it really just depends. And so it depends on exactly when these symptoms might be occurring. And so if we're considering a woman who is before the age of 40 years old, who has not had a period in 3 months, then we really got to make sure that this woman has not experienced premature ovarian insufficiency or premature menopause. Okay. And so that's really important because that has significant implications for her cardiovascular and bone health. And so that, and, cognition and all those things. So it's really important to kind of figure that out. Once you realize that that woman is not in a premature menopause situation, then there's a lot of different
Can I just stop
ideas
you for a
about
second? Because
when and
let me stop you. You mentioned that, uh, and I want you to talk about the rest. But how common is early menopause? How commonly does that occur? Because a lot of women hearing you say, "Oh, I've got that," and I'm 35 years old. How common is that very early menopausal period? How
it's
conservative?
incredibly uncommon. It's
Wow,
it's
wow, wow,
like
wow. That's
less than
news to me.
2%.
Sorry,
Yes,
what was
it's
that percentage?
incredibly uncommon. It's about less than 2%, and it's
Okay.
really common with, or more common with women with autoimmune disease, Graves, adrenal problems, those kinds of things, and other, autoimmune disorders like lupus and stuff. So, but not really common in the general public.
Okay, that so carry on then. When do you, so that's the one group, that's a smaller group. When should women begin to be somebody that doesn't have that premature or early menopause? When does somebody, and obviously not the group that has surgical removal of their ovaries, but somebody going through a time of life, when do you begin testing? And is it in response to symptoms, or do you just test based on age?
It really depends. So symptoms are the most important, and we call this the climacteric state, which means the 10-year evolution of to the time where a woman actually does not ovulate for 1 year. Okay, when you don't ovulate for 1 year, that equals menopause. And on average, that is about age 51, but it can occur 10 years before this like evolution of maybe some hot flashes, maybe some vaginal dryness, maybe some brain fog, maybe some irritability or short-tempered feeling, maybe fatigue or insomnia. And so maybe a couple of months of a skipped period, it really just depends. And so one thing that is not in fashion with a lot of OBGYNs and sometimes with me too is that I don't always check these hormones because it's incredibly invalidating when they're normal. Okay. And so the thing is that we want to make sure if a woman hasn't had a period in 3 months that she's not in menopause early, and that's before age 40 or 45, depending on what we're trying to treat. But after that, when we know that she's not, it doesn't mean that her symptoms of hypoestrogenism or low estrogen aren't valid. It just wasn't caught in the test. Okay.
Right.
Because there's so much variability with these hormones. And so then if I were to tell a woman who has hot flashes and vaginal dryness that her estrogen level is normal, then it makes the woman feel sad. It's like, well, then what is it? And so, so many of those times, these saliva tests and blood tests and things like that don't really have a lot of clinical utility. We really just treat the symptoms. And if a woman is experiencing these symptoms in the age group of within 10 years of the expected time of menopause, then she's in perimenopause and that's it. And then you go on and start treating.
Wow. And if a woman is on birth control, how does that affect, especially the cyclical birth controls, how does that affect symptoms? How does that affect your measurability of menopause? And are there some women who continue on birth control through the perimenopause or through menopause inadvertently, especially if it occurs early? How does that affect them?
Yeah, it also depends. So if a woman is on a combined hormonal contraceptive, so like a patch, a pill, a ring, anything with estrogen and progestogen, then those hormone levels will actually suppress the ovulatory factors in your pituitary gland to cause the ovulation and in your hypothalamus to cause the ovulation signals because it's doing its job of suppressing ovulation. So when we measure those hormone levels for women, that are on hormonal contraceptives, it's often incredibly difficult to interpret because of the natural suppression that it will have from being on these external hormones. But you're right, many women will be on these estrogen, progestin medications for years, even, beyond 51, 52, 55, and they don't really know when they're in the phase of menopause. And so sometimes we just say, well, stop it for 3 months and just see what happens. But the really cool thing is that a lot of the options for treatment for menopause hormone therapy include, estrogen, progestin, contraceptive therapy, and that's just fine. It really depends on what a woman is looking for.
So is that again, just as a guy and kind of not expert on this, why not just continue your birth control for a longer period of time?
You absolutely can, and there's no problem with that. You just have to do like a reassessment of risk factors, but yes, there are some women who, they all of a sudden their cardiovascular disease risk starts to go up and stuff, and so you have to kind of talk to them about potentially other options or continuing options, and I'm sure we'll get there, but a lot of the bioidentical hormone therapies have a lot less of the cardiovascular disease and thromboembolic event or blood clot risks, and breast cancer risk than the synthetic hormones, and some of the synthetic hormones can be found in regular birth control pills. But really, I used to have a professor in endocrinology who would teach us in residency and say, "Oh, you can keep those birth control pills going until you're 81, until you die," because so many women feel so much better on even a synthetic hormone that they would prefer to stay on it than to stay off of it.
Right. And that's interesting because I hadn't even thought that through. That makes all the sense in the world. So let's look at the majority of women that are going through menopause, 40s, late 40s, early 50s, kind of the standard block. When somebody comes to you and says, look, I think I'm going through menopause, I'm right age, I'm starting to have some minor symptoms. What are the tests that you order? What types of tests do you order in order to assess a woman through menopause, and then potentially with a view to possibly supplementing with HRT afterwards? So what is your test algorithm?
Yeah, so this test algorithm for women in that typical age group, I would always include a thyroid function test to make sure that I'm not misdiagnosing hypothyroidism, hyperthyroidism as potentially a perimenopause symptom. A lot of times, just looking at a hemoglobin A1C, looking at insulin levels, and also looking at a complete metabolic panel, but also looking at CBC, looking for iron levels, because a lot of these fatigue symptoms could be, iron deficiency. Sometimes they can be, a diagnosis of prediabetes and, that hot flashes. And so a lot of times we know these uncomfortable hot flashes are very much associated with women of metabolic syndrome. And so we also want to make sure we're not missing that. And so those are the major
Let
panels.
me stop you
You
for a second.
can,
How many
uh-huh.
gynecologists actually do that? Because in my experience, it's very rare. And
Yeah,
it's so
I don't
important.
know.
So important.
I know, right? I wish we all did it more because we actually are primary care doctors. And the thing is, we really need to see a baseline of that because once we do, then we have to kind of know what does the lipid panel look like? What does the metabolic syndrome evaluation look like? Because sometimes we know that when we put patients on certain types of menopause hormone therapies, it can kind of worsen those panels. And so we have to have an understanding of what the baseline is.
And again, that
Now, I
that
know a lot of people are looking for me to say, did you order estrogen? Did you order progesterone? Did you order testosterone? And you know what? I'm actually going to be the doctor that says, no, I don't, for the typical woman who's experiencing it, because I don't need those numbers to tell me that she's in perimenopause. I just want to make sure I'm not missing anything else.
and you know what? I absolutely love that answer because so many docs are focused on the specific female hormones that they ignore all the other things. Now,
Right.
assuming all the other things are tested for and they're okay. So you say you don't order the classic female hormones. Is that
That's
correct?
right. Not in the perimenopause. If I'm making sure that I'm not missing early menopause, I will. But in the typical age state that you were mentioning, I don't feel the need to.
And
And it's not recommended.
if you're going to plan to do HRT afterwards, how do you evaluate dosing if you don't have a baseline?
Symptoms. And that's because everyone is different. So someone's dose of, a transdermal estrogen patch is going to be a different experience as someone else's because of their adiposity, because of how they're processing, and so because maybe their cardiovascular disease, current risk, it really just depends. And so we really go based on symptoms, not on numbers.
Who should be on hormone replacement therapy? Looking at that perimenopausal group, who should be and who shouldn't be, or is it? Well, I'm going to leave it that open. What are your indications to treat? What are your indications not to treat? Because some women choose to, some people don't. What are your recommendations? How do you manage your emphasis on HRT for somebody in the perimenopausal era? And at what stage through that process do you begin treatment? Do you begin early? Do you
Yeah,
begin
so
late?
a lot of this is kind of normalizing, right? A lot of times women will come in and they just want to feel like a normal person. Like, is what am I feeling a part of what my age process is showing me that I'm going to experience? And sometimes like 95% of the like work that I do, if patients have all of these subtle symptoms and we're not missing anything more serious, my validation of just being like, yeah, like you're feeling like you can't sleep or you're waking up at 2 in the morning and you can't stay asleep, or it's taking you 2 hours to get to sleep, or you're maybe feeling hot in the room and everyone else is cold, and maybe your hair is getting thin, right? All of these subtle things. Sometimes like the patient just really wants to hear validation, and it's like, yeah, that's kind of what we're dealing with, and what do you want to do about it? Oh, okay, and it's funny because 95% of my patients are like, thank you, doc, I'll see you in a year, and then but the other patients, some of them are like, wow, no, I'm actually having really severe vasomotor symptoms, which means like I'm soaking through my bedclothes, or like I can't sleep well at night because I'm just so hot. And those are pretty serious quality of life issues where it actually impacts our sleep, right? And when we're younger, like we don't even think about how important sleep is. We just go to sleep. But when we start to get a little bit older, we have a hard time with rest, and insomnia really comes up. But if you were to look at like the textbook and like what the major recommendation is for the FDA approved use of menopause hormone therapy, it is moderate to severe vasomotor symptoms or like hot flashes in the systemic use. But if another woman has, vaginal dryness, or what the new term is called genitourinary syndrome of menopause, topical estrogen therapy is okay. And those are the FDA approval. Now, everything else that we have is all off label. So if a patient is looking to, treat their insomnia or their brain fog or their feelings of depression, and anxiety on menopause hormone replacement therapy, which we know there is good data to support, but it's not like an official recommendation from the FDA. It's okay to start that. You just have to tell folks like these are the risks and the benefits, and we'll get into that, but there are a lot of subtleties here that are really important to kind of share with patients, that in the Women's Health Initiative in 2002 kind of messed up a lot of things for us OBGYNs and doctors, because the Women's Health Initiative was, a big trial that looked at how is it that hormone replacement therapy can help women and their cardiovascular disease risk, right? It wasn't even like about, hormones necessarily in the way we think about them in hormone replacement therapy for hot flashes and things. And so, and that trial was based on women who were on synthetic hormones only. And so we're not even talking about like the major recommendations for using bioidentical hormone therapies, which is really important. And in fact, like our BOCA conference in January is going to talk all about this, and it's really exciting. But that's really important to know, is that this trial didn't even talk about actual bioidentical hormone therapy, which is actually the recommended first line
Let me stop
therapies
you.
for
Let me
all of these
stop you for a
problems.
second, because I think that everybody wants clarification. We're throwing around terms here that you're very familiar with. Can you explain what a synthetic female hormone is and what a bioidentical is? How are they different? Which are preferential? When, what circumstance? Discuss the different types of medication out there and why we use these words and what the importance is of these words to each patient.
That's right. And so we think of the word bioidentical as being exactly what your body produced naturally on its own, exactly what the ovary produced, estrogen and progesterone on its own, estradiol. Okay. Now we have synthetic hormones that are, oh, pardon me, let's go back to bioidentical. There are FDA approved formulations actual drugs, pharmaceuticals that are bioidentical. Okay. Then we have synthetic, which are also estrogen and progestogens or progestins. They're not progesterone. Okay. And these are because the actual hormone was modulated just a little bit so that they can actually be marketed and sold as brand name drugs. Okay. Now, when we look at that, their affinity for certain estrogen and progestin receptors in your body are a little different than what bioidentical hormones were meant to do. And so in the synthetic hormone space, and those are the ones that you see in the hormone brands called Premarin or medroxyprogesterone acetate. We call it Provera, all of the other birth control pills. Okay. All of those have ethinyl estradiol, which is not, 17 beta hydroxy estradiol. It's different. And so all of those formulations are actually brand named and marketed because of a little bit of a difference in the actual molecular structure. And
So they
so,
are
and
not the same
they're,
as what the
they're
human body naturally produces.
they're not the same.
Whereas the
Yeah. And so even
bioidenticals
though
are the natural formulation. They may be made in a laboratory, but they've got the same chemical formula and structure as what you naturally produce.
correct, correct. And so the big concerns on those big studies that made everybody scared were based on synthetic hormones, okay? And on the marketed ones, there are definitely marketed bioidentical hormones, and there's plenty of wonderful safe options. And the other options, and here's the thing, the other options, synthetic ones, are safe too. You just have to understand the risk and have those understanding of what's best for the particular patient in front of you. But yes, there's synthetic hormones
How
and
big a difference
bioidentical.
is there between the two categories? Do you make a big distinction? Do you use preferentially one versus the other? Or is it really more a psychological difference that's really not that palpable clinically? What do you
It
think?
depends. When a woman is on birth control pills, let's say, and those are synthetic, and if she likes them, we can continue that for as long as we need to help with her symptoms. But if a woman who has never had any kind of hormone replacement therapy before and then is starting to have these symptoms, the recommendation is to start bioidentical hormones first. And that's very easily done. And but a lot of folks are kind of misinformed. Just a lot of practitioners are misinformed because of these big old studies that brought a lot of fear in practitioners' eyes of how to properly use them. So yeah, yeah. But the recommendation, and I personally, and the recommendation is to use bioidentical hormone first.
Yeah, and I think that's one of the things that I've learned, and I'm a big spokesperson against. And hopefully, this is going to change. I don't want to get political. Hopefully, it's going to change over the next while. Is our reliance on some of these studies, as you've pointed out, is tangential, and really the studies don't give us the information we need, particularly in the metabolic space. And to get FDA studies and FDA approval, it's usually sponsored by pharma. There are certain biases, certain agendas. So I tend to be aware of these studies, but I ignore them in my decision making with my patients. I take the patient into consideration. That's what I love about the way you practice, is that, okay, this is what the studies say. This is what I prefer, your choice. But we leave the choice up to the patients. But we have our
That's right.
experience and our knowledge in the metabolic space to give us guidance.
Oh,
Um,
yes. And it's even more confusing because even in folks who receive bioidentical hormones like estrogen and progesterone, in the package insert of the medication has the same risks and concerns based on the Women's Health Initiative in 2002 from the synthetic hormones. Okay. So even when a patient goes home and feels like they've made the right choice, the package insert of the medication refers to the risk of not even the same medication. So it's
wow.
important to keep that in mind.
And is there a big risk difference in your opinion?
Yes, there is. There is a lot less of a risk for cardiovascular disease concerns as well as thrombus or blood clots. It's a big difference.
So, just along those lines, I'm going to deviate a little bit. When you typically put a patient who's coming to you primarily for perimenopausal symptoms, when you put them on medication, do you also tack onto that a metabolic discussion? Do you talk to them about diet? Do you talk to them about the ancillary things? Most doctors are just out there writing prescriptions, off you go. Um, do you make this more, I hate the word holistic, but do you make it more global and talk to the woman about changes she could make dietarily that's going to improve her and reduce those risks? Or do you just put them on the medication and see what happens?
Well, and then that's why you and I get along so well because it's lifestyle first, right? Lifestyle first. And the important thing is that there's even a role for discussion of lifestyle changes in the climacteric state, the perimenopause, transition. And that's because the decline in estrogen starts to remodel how we carry our fatty tissue. And so what happens is that decline in estrogen shifts how we carry our adipose tissue in women from our hips and thighs to our belly. And we all know in this space that belly fat is visceral fat, which is way more insulin resistant than a lot of our peripheral fat in our hips and thighs. That's a function of declining estrogen in the perimenopause and menopause state. That's why a lot of women in this time of their life have struggles with losing weight, and they're always talking about belly fat, and that has to do with the declining estrogen. So when we talk about how does lifestyle play a role, well, we know that women who have more metabolic disease have worsening vasomotor symptoms, hot flashes, menopause symptoms that occur for longer because a lot of times we don't focus on declining the insulin levels and the inflammation that a woman comes with. And so vital to the conversation. You can't just give someone estrogen and progesterone without telling them kind of how they got there. And so then that's the true essence of shared decision making, right? Because then if you tell folks, okay, if you start a well-formulated ketogenic diet or a low-carb diet or a carnivore diet to decrease that insulin level, or maybe it's not diet, maybe like their insulin levels are high because they're stressed out at work, right? Or maybe because they're in a toxic relationship, whatever it is that's causing that rise in insulin, we have lifestyle ideas to reduce them, right? And then once we reduce that belly fat, and then eventually we'll have, less of those menopause symptoms, right? But we have to tell people how they got there. And then if once people are like, yeah, I think that's good. I've done as much as I can. I'm ready for the next level of hormone replacement therapy. And then that's when you get to, decide with them what makes sense in terms of medications and stuff. But vital to what you're saying, you have to talk about lifestyle.
And I think you bring up a very important point that I want to re-emphasize because the majority of doctors, in particular gynecologists, number one, don't test this particular thing. And number two, even if they do test it, don't know what the hell it means, don't know how to interpret it. And that's insulin. Insulin is a regulatory hormone, and insulin regulates steroid hormone production of all different types. So, in the testosterone estrogen conversion, it's an aromatase. I've got it written down here, aromatase activity stimulant. So there are all of those productions in males and females of estrogen and testosterone. The hormone, yeah. So I think that insulin is such an important thing, and we really have to know about insulin if we're going to determine what's appropriate for a woman and how to convert things across. The question I have for you, you've mentioned a lot about estrogen, estradiol. Estradiol, just let me clarify, is the active component of estrogen. So,
That's
and then
correct.
progesterone.
Yes. Mhm.
And then, but you haven't mentioned testosterone and you haven't mentioned DHEA. Why don't you just comment on those two hormones that I see a lot of nurse practitioners and gynecologists put patients on what I think are mega doses of testosterone and DHEA in the face of an already elevated testosterone because they don't test the levels. What's your approach to those two hormones?
Uh,
Can you give us clarification and understanding of what they are, how you approach them?
So this testosterone is the only hormone that we should be testing if a woman is started on testosterone therapy. Okay. So that's the only one. So let's talk about testosterone and what its indications are. So we're operating in like in currently right now no major FDA approved recommendations for testosterone for women, number one. Okay, so that's the first thing. Once we get outside and have that understanding of this off-label use, the use of testosterone in menopause hormone therapy is for hypoactive sexual desire disorder, okay? Which means that women have kind of lost their interest in sex, their libido. It has nothing to do whether or not they can climax. It has nothing to do whether or not like their vagina or vulva feels really dry. That's a little bit different. But this actually refers to their interest in sex and their loss of libido. And so testosterone transdermal gel has actually been very well documented and is safe to use in women to help treat these disorders, right? So that's really great to hear. But here's the thing, we have to make sure that we keep the dose lower than the premenopause level. Okay. And so that requires checking levels, every 6 to 12 weeks to make sure that we're not superseding that level. The reason why it gets concerning is because these super doses that you were talking about that sometimes can be found when we place, like when we do troches, which are these little lozenges that go in people's mouths or pellets in people's arms, is that sometimes we can have these mega doses and that aromatase can change the testosterone into estrogen and cause increase in the lining of the uterus that increases a woman's risk for endometrial cancer, but it can also increase the risk for breast cancer too, and then cardiovascular disease concerns. And so those are really serious things. And I have had many patients in my office who are really irregularly bleeding, and the folks who don't have a really a high level understanding of this physiology. It's actually not high level. This is stuff that we all learned. Is that like, we have to make sure that we're not missing endometrial cancer. And I've had many patients in my office where I diagnosed endometrial cancer from an outside practitioner who is operating way outside of their understanding, right? So we do have to, that's the only one that I will check. If I start a woman on testosterone gels for hypoactive sexual desire disorder, then yes, we have to make sure we monitor that. So that's testosterone.
The
So
other
if
thing
we're
I do see, Andrea, is in we test testosterone in males and females all the time, and it's quite common in my PCOS patients or the patients that have come from a PCOS background to have already very high testosterone levels. And so often it's not tested for, and then they add testosterone therapy on top of an already elevated testosterone level. And it really is, to my mind, criminal not to be looking at the baseline hormones like you do before they prescribe these. And so many gynecologists and certainly the nurse practitioners that often manage these have a protocol. They don't take the individual into consideration, and everybody goes on the same protocol. Along those lines, what about DHEA and DHEAS, the sulfate? I see a lot of our patients with HRT are put on DHEA. What are your thoughts about
Yeah,
that? What's the reason? What are
so
the
there's no good data, okay? And a lot of folks are doing this for adrenal fatigue symptoms, right? And so, DHEA comes from like the adrenal gland, and that's kind of where a lot of our regulatory mechanisms for stress come from and how we manage those things. And so a lot of folks feel during the menopause transition that they're experiencing more short-tempered feelings. They're feeling more irritable. Their ability to manage stress is a lot different than what they were when they were in their younger years. And so a lot of folks are giving DHEA supplements, and then DHEAS is just kind of like the reservoir of active DHEA that's there in our body. But there's actually no data to support its use. And so that's really important to know. And then we know that that's actually a building block for other hormones. So we have to actually be really careful about our use. And so the other hormones are as testosterone and estrogen. And so we don't want to be making, too much of a reservoir for that change to happen in our body. But there is a very cool DHEA topical cream that we can give for women who have genital urinary syndrome of menopause or vaginitis or atrophic vaginitis, because a lot of the estrogen and testosterone enzyme cofactors in the vulva can change DHEA into estrogen and testosterone in the vulva and cause a lot better elasticity. And so that medication is called progesterone. It's very, very helpful, but that's only used topically and it should not be used orally.
Yeah, I think that's the key thing for me. So often, because DHEA is a precursor to these other hormones, they say, well, okay, we're going to put you on a bunch of DHEA and hope your body does the right thing. We have the bioidenticals for the end products, the testosterone, the estradiol. Why not just put them on the end product instead of hoping that the body's going to do the right thing, particularly in someone with insulin resistance? So those are little places where I've not understood the rationale of doing that. Um, the next question for you is, I know we're talking about women that are naturally going through the menopause, but what do you do when you um, do a hysterectomy, do a BSO, which means you're taking out the ovaries? At whatever age, for whatever reason, how do you manage those patients through the sudden? Because it's crazy, in my opinion, how many women lose their uteruses. I mean, for some gynecologists, the presence of a uterus is an indication to remove it. And when I look at the story, um, what do you do when somebody's having a hysterectomy, particularly if they're losing their ovaries as well? And
Yes, so
let me back up. Is there also an indication if you don't need to take the ovaries out to leave them alone? How do you monitor that? Because there's a risk of ovarian cancer. Tell me a little bit about the decision making and what the concerns are.
Yeah, so the discussion that we have with patients when it's time to remove a uterus usually also often involves should we take your ovaries or not, right? And so it really depends on ovarian cancer risk. Now, the lifetime ovarian cancer risk is 1 in 70, which is about 1.7%. So it's not that high. But if a woman has a higher family history of ovarian cancer or they're actually carrier of the BRCA mutations, then we do recommend that it's
Which is the
important
same
to
one that affects the breast.
correct, yeah. And so it that shared decision making is really important. And yes, and so removing them is helpful. But a lot of times folks worry about the upcoming impending ovarian cancer risk, even if there aren't carriers of those gene mutations. So if you do remove ovaries, it's recommended to continue estrogen therapy up until the point of average natural menopause, which is about age 51. So that's
Estrogen
really
by
important.
itself or estrogen with progesterone?
Estrogen by itself, because the role of progesterone in estrogen and progesterone therapy is to stabilize the lining of the uterus so you don't increase the risk for uterine cancer by too much estrogen without the stabilizing cofactor of progesterone. So estrogen by itself, and some people will add progesterone depending on how people feel after, but we always just start with bioidentical estrogen.
Yeah, and that's
So
my
that's
simplistic understanding is that a woman who's had a hysterectomy can be okay with estrogen by itself, but if you still have your uterus, you should be on a combination of the two. Is that correct thinking?
that's correct. Yes,
Okay.
yes.
And so
Yeah,
often we
yeah.
see that that's not necessarily the case.
No, it's really hard because some people are afraid of this ovarian cancer risk when the risk doesn't actually apply to them, or some docs are just misinformed and they don't want to put people on them. And then we have to think about bone health, right? Because estrogen is really important in bone health and prevention of osteoporosis. And
So
so
let me stop you
actually,
for a second. Let's do that as a topic because I've got in my notes here, let's talk about osteopenia, osteoporosis, and the role of HRT, the non-gynecologic role of HRT in bone health.
yeah, so estrogen hormone replacement therapy, menopause, they call it the new term is menopause hormone therapy, is one of the uses is for prevention of osteoporosis, but not treatment, right? And so once you already have low bone density or osteoporosis, the actual recommendation is not to use hormone replacement therapy as treatment for those disorders. Okay, so that's really important, but it's actually one of the recommendations for prevention, which is
Right, and
which is
that's
like
something I've never understood because
I know, right?
osteoporosis, osteopenia is not binary, it's gradual. So
Right.
even if you've lost half your bone mass, why don't you be on something at least to prevent the other 50% from disappearing? That is a concept I've never understood, and that's why I kind of am aware of, but somewhat sideline some of those guidelines and recommendations because we
Well, yeah,
practice
you wouldn't
outside of
be the
that.
only one. Gynecologists do that too. I don't even remember the last time I've given a woman a prescription for menopause hormone therapy for the prevention of osteoporosis. Like that's just not something that we do because we never know about it. We're not really thinking about it. We're thinking about the other symptoms that women have. It's absolutely indicated, but it's just not really on like the radar, you know? So yeah, because by the time we find out about it, they're already, a lot of women are already struggling with the other diagnoses, and then we have to treat it based on that. So
Yeah, and that's something that's just a slightly off topic, but this whole concept of osteoporosis and osteopenia, don't wait until you've got it. You're not going to get it back. Assume that you're going to get it and do everything you can, lifestyle, diet,
yep.
hormonal therapy,
Hmm.
and appropriate micronutrients to prevent it. Because getting a DEXA scan to measure it, by the time you've measured it, it's too late.
Yep. It's too late.
Yeah, so intervene early. So, in terms of the medication, the hormone replacement therapy, there's a variety of different mechanisms. Let's start with the bioidenticals by which women can take it. Um, what are your thoughts on which methods do you think are most effective in terms of dosing, and which are the most acceptable? Which are the ones that you prefer to how would you prefer to give it? All the way from pellets to vaginal dosing. What is the range out there? If you can discuss the full range, and then tell me the benefits and downsides of each and which you prefer.
Yeah. So there is what we call systemic hormone therapy, and then there's topical hormone therapy. Okay, so systemic means that when you receive hormones, your whole body is going to be affected. Now, topical hormone therapy is typically reserved for genitourinary syndrome of menopause or vulva, atrophic vaginitis, the thinning vulva, the laxity issues, the painful intercourse issues. That's topical. That's most of the time it's estradiol, topical estradiol, or progesterone, which is that DHEA, and very, very helpful for those two things.
Are
And
they
they're
absorbed though?
bioidentical.
Is there a systemic effect? Is there a whole woman effect?
There is not. There is not. And so actually it is so safe, and make sure that when patients talk about it with their oncologist, but even for women who've had experienced breast cancer, it's still absolutely recommended to have a discussion with your oncologist to use topical hormone therapy if you're experiencing genitourinary syndrome of menopause. There's
But
other
let me
really great
stop you because
options
the flip
too.
side is also true then from what you've just said is if you're experiencing fatigue, sleep issues, the global hormonal dysfunction, the whole body women dysfunction, using a topical or a vaginal medication is not going to improve those symptoms. Is that correct?
That's right. That's correct.
And then
So
does the
the
systemic
topical.
does the systemic delivery improve the sexual function and the local vaginal area? In other words, so comment on those two. That the topical
Yes,
doesn't help the whole woman. The whole woman therapy, does that help topically and gynecologically?
yes and no. So we always start with the systemic hormone for women who have like those whole systemic issues. And so that can either be transdermal patch, so like a patch, or an oral pill. Now, the preferred recommendation is to use a patch because remember, anything that you take in your body first has to go through first pass metabolism of the liver, right? And so the liver will degrade a lot of like the active effects of those hormones, and you'll need more of a dosing. When you go with a transdermal patch, you avoid that and it goes directly into your circulation, and it's more we're able to adjust those doses in a better and more effective way. So topical patch, and then you can take a vaginal or oral progesterone capsule. Okay. And so this progesterone capsule is bioidentical. So when we use both of them together, it does help that global system of, those low estrogen, low progesterone effects of hypoovulation, not ovulating, so that what you were getting, those hormone levels that you were getting before. So
Is there
that's really
vaginal
great.
absorption? Is there vaginal absorption that affects the entire body, or is it purely for topical use and not absorbed?
So there's an oral capsule that you can take, and that's really great. And then a lot of people, sometimes will maybe get a little nausea. So you can actually give higher doses of vaginal progesterone in the capsule, and that is not that is actually considered systemic, which is
Okay,
great.
that's what I want to know because you
Hmm.
mentioned the distinction.
For
So,
progesterone only, for progesterone only. Hmm.
okay, but
Hmm.
estrogen, if it's going to be systemic, it has to be taken transdermally or orally. There's no
That's right.
estrogen that is vaginally bioabsorbable systemically.
Yes, there is. There's a ring that comes in, and there's a ring that actually does the same effect. And there's so many different formulations, but to keep it simple, I just wanted to talk about oral and bad and transdermal. But yes, there is also a ring that can also deliver systemic effects as
But
well.
there's one you didn't mention, which are the pellets.
Yes. So I really do stay away from those because you can't dose them very well. So once you receive it, it's really, really hard to adjust the dose. And again, you may be overdosing and you'll never know. And then you'll get this irregular bleeding and you have to follow that and make sure that you're not missing endometrial cancer. But we're also talking about breast cancer risk. And so everybody receives and um, modulates those hormones like in a very different way. Depends on how obese you are, depends on whether you're someone that contains their obesity more in their center. And so it really just depends. And in fact, the recommendation is if you do have diabetes or pre-diabetes is to start a woman on transdermal rather than oral because it reduces the risk factors of the rare risk factors that were looked at that of cardiovascular disease problems, high triglycerides, but also blood clots. And so the recommendation is if you do have diabetes is to look into doing a transdermal patch over oral.
Should every woman starting HRT have a CAC score?
I think every woman should have a CAC score, period. And
I like that. But it is an opportunity to intervene with a metabolic test that nobody else does. So
that's
I
right.
think it's an opportunity, even if somebody's not interested in metabolic health, they've got diabetes, pre-diabetes, insulin resistance, it's a wonderful opportunity. And also it can affect, as you've talked about a lot, HRT can affect cardiovascular status. So you want to know what your baseline is up front. And there's a call to action if it's positive. It's a wonderful opportunity to intervene. So I just wanted to throw that one out there because you're right. I start at the age of 40, but it is a good place for other gynecologists and folks that may be listening to this that are prescribers to say, okay, as part of the baseline testing, let's get a CAC. The other question I
That's
have for
right.
you, I know this occurs a lot with the testosterone gels and things. Is there a rub-off effect of a dermal patch? In other words, if you've got a partner, if you lie in bed with them or you have physical contact with them, is there a rub-off effect? Because I don't want a lot of estrogen in my body, just like I don't want my wife to get a lot of testosterone if I was to use testosterone as a gel. Is there that risk?
No, there is not.
Okay. Because we see that a lot with the testosterone gels, and that's one of the reasons I'm not a fan of the testosterones. Okay, how long should
Sorry,
people?
my I have a little bit of a cough. My husband was making a lot of fires in our fireplace recently. I have a little reactive
Okay,
cough, so I apologize, guys.
no problem. So the two questions that I'm going to roll into one. How long should a woman be on hormone replacement therapy? Does the risk escalate? And secondly, if I see somebody who's maybe 8, 10 years out from menopause, but they're having a lot of still the global female symptoms, the fatigue, or is there a time period where HRT is not going to benefit or shouldn't ever be started? If you've got someone 58 years old, they went through menopause 48, 50, is there a time period where you shouldn't start it or it's just not of any value? And should there be a stopping point? Should there be an end point?
So this is a really great question because a lot of gynecologists struggle with this answer as well. But by and large, if a woman is having menopause symptoms, let's say hot flashes or insomnia, and they're more than 10 years out from menopause. So let's say they had those symptoms and then they went away and then they restarted 10 years later. That is not an indication for menopause hormone therapy. Okay. That is to start looking for other reasons why she has these problems. Okay. So it doesn't like recur after 10 years. Okay. So that's really important. But let's say that this 58-year-old woman who's had these symptoms, but were never treated, and still 10 years later, she still has them, then yes, absolutely. But if they resolved and it's been over 10 years since menopause, the recommendation is not to start hormone replacement therapy. It's to look for other causes.
What about female dryness or loss of libido when they're older? Is that an indication? In other words, is there a local gynecologic indication maybe for using topical when you're
Yes,
older?
topical is different. So when I was referring to is mostly for systemic, but yeah, topical is totally different. For sure that you can, start and stop as, as the body kind of shows us. Now, the other question you had was how long do you continue systemic hormone therapy? That is a personal choice and a shared decision-making moment with the patient. And so, the on paper discussion is really like 5 years, lowest dose, shortest amount of time, stop when they are done with their symptoms. But a big wave in the menopause societies is to continue it for as long as a patient really feels like they need, and to really have those shared decision making and reassessment of risk factors. So we haven't really talked about women who are not candidates for hormone replacement therapy. And so this is a really good discussion about when to reassess to decide when it's time to stop. And that's certainly if a woman has developed any hormone sensitive breast or uterine cancer, if she's ever had a blood clot, so a thrombus in her heart and her lungs, if she's ever had any unexplained vaginal bleeding that we can't figure out why, or if she's had a heart attack or a stroke. If
Are
she's
those
had any,
absolute reasons not to use
those
HRT?
are absolute contraindications. Yes.
Because we
Mhm.
see that a fair amount, and very often in my population, that's a population who are metabolically in awful shape, had their DVT, had their cancer, or whatever it may be. Now they're in metabolically really good shape, but they have these perimenopausal, they might have had cancer when they were younger, or DVT when they were in their 30s or 40s, or a pregnancy DVT, or whatever it may be, and then they massively improve their metabolic health. Now they're sitting, I'm feeling awful, I'm going through menopause, and my doctor won't put me on medication. What do you say to those folks? And is there a variability to risk assessment based on what you've had?
Yeah, that's a really challenging patient because, you want to congratulate them and show them like, wow, you've done everything you can. Now you're in a totally different state. The important thing to realize is that menopause places a woman's risk for cardiovascular disease at the same level of a man at menopause. Okay. So that's why there's like a higher risk of, hypertension, diabetes, atherosclerotic disease for women once they go through that state. If they had those problems, even with the protective cofactors of estrogen before menopause, we have to be really careful with these women when they are in the menopause state because they already have that predilection for these metabolic and healthy dysregulatory states. Now, so then it's like, well, what do we do with them, right? So there's like all kinds of other non-hormonal based therapies that also really work well with like changing a lot of the hot flash receptors in our brain. There's even SSRIs that help with that. There's all kinds of other topical therapies, and topical therapies can be dealt with, and we can manage that with those women. But by and large, with systemic things, there's other multimodal therapies that we have, but that don't involve estrogen and progesterone.
And does the topical use of the estrogen have the same carry the same risk when you've had is that also contraindicated when you've had some of these health issues or not?
No, it's not. It's not. Those are the only big one that we just have to be cautious about is the estrogen sensitive cancers. And so while, the American College of OBGYNs and all these big societies say we should be offering it to them, but it's also a shared decision making experience with their oncologist and the patient about whether it's right for them.
Yeah. And you see, here's also the perspective that I have is I understand the current consensus, the current algorithm, but it absolutely does not take into account metabolic health. And there
It
are,
doesn't.
we've seen this massive increase in my career as a physician. Breast cancer when I was a medical student was rare as rocking horse manure. It was very exceptional that people had that. Now it's 1 in 7 or 1 in 9 people are going to have breast. So that isn't because of the genes, it's not because of estrogen, it's because of metabolic dysfunction. And we know insulin is a cancer regulatory hormone. So while the data still supports, and us as physicians are not willing to take that risk, I'm not certain that the data is true in outside of consideration of metabolic health improvement. Does that make sense?
Oh yeah, I agree because those studies haven't been done, right? They haven't, we don't have those studies on women who had really high levels of cardiovascular disease risk and then got better, and then we put them on hormones. Like we just don't have that, but we do have the knowledge of what the physiology is of women and their cardiovascular disease risk after menopause. And so that part is just really hard. And again, shared decision making with the patient, and then you just kind of decide with them, about what makes sense. So.
And that is exact. I like that a lot because really it is okay. These are the risks. These are the benefits. Which risks are, when you've got full knowledge, which risk are you willing to take, and are you willing to change that lifestyle or continue to live that lifestyle? That is something physicians have become very paternalistic and very absolute because of the guidelines. And
Yep.
we often don't individualize therapy. And I think you and I are so good at getting to know a person as a unique individual rather than plugging them into an algorithm. And that is so crucial in everything we do, in particular when it comes to hormonal therapy. I personally don't prescribe, but I'm to a degree knowledgeable, and then I refer to you to do those prescriptions. But there's a different reason I don't prescribe. However, I do think that care should be individualized. And even if the risk is increased, you've got to look at the symptoms that you're treating and have that woman decide for herself, together with the knowledge you provide, which risks am I willing to take, which am I not willing to take?
That's
Are
right.
you in
Oh
agreement
yeah,
with that practice
I
as well?
agree. I think that we've gotten so lost with guideline care that patients and doctors feel frustrated that they now don't have flexibility to treat patients, right? And so, oh yeah, that's a whole other discussion about where we brought ourselves in medicine, with guideline care. And so it takes away the actual individual who's in front of you, and then where they can make the risk. And it's even taken away a lot of the thoughts that a lot of physicians and healthcare providers can actually do for their own, right? They don't even have to rely on their physiology anymore. They just look at the guidelines, and that's an unfortunate state to be, and that's kind of where we're moving, and it worries me all the time.
The last question that I have in this regard, in terms of my notes over here, is we see a lot of patients, as you mentioned earlier on carnivore diets or ultra low carbohydrate diets. We see women that have, as part of that algorithm, starting to exercise like crazy. Um, First question for you is, what impact does a carnivore diet, a low insulin level, exercise have? How does that affect your decision and the impact of hormonal replacement? Do you lower doses when someone's more hormone sensitive? How do you manage a carnivore or someone that's starting a carnivore diet? How do you manage somebody that's exercising like crazy, that's running endurance races or doing hip training or whatever it may be?
Yeah, it also depends. So I think if a woman's coming to me and they have vasomotor symptoms, we know that those are highly correlated with poor metabolic health. And so it's kind of like the lifestyle like choice first. I'm going to start by losing weight and building my muscle mass. And then, if that helps my hormone concerns, then I don't need hormone replacement therapy. That's great. But let's say they've been on a low carb diet for a long time, or they're endurance runners and stuff, and they just need a little extra hormone to help them through that transition. We just start them on the same dose, that's, recommended for everyone. And then we adjust depending on what their symptoms are. And that's usually every 4 to 6 weeks, we'll have them come back and have an ongoing discussion. But we know that women who are on, low carb or, carnivore diets actually have less of those problems in the long term. But of course, in the beginning, women who are struggling so much, who just want to feel better, we often use a multimodal approach, right? It's like, okay, here's some hormones, here's your diet recommendation, because they need relief at that moment, right? And that's okay too.
So I hear you here, and it's a different concept. It's a concept that I'm learning from you right now is symptomatic management. But here's the question. If you're going to start them on the recommended dose and the symptoms go away, how do you measure overdosing?
That's a good question. Um, It's gosh, the pharmacokinetics of all of these medications are such that that it's you have a very unlikely chance to overdose, and what would be ideas of what would be signs that would suggest overdosing? Well, I think in one sense it could be breast tenderness, like really just like a lot of breast discomfort or palpitations. We see that a lot with progesterone, all the way up to like insomnia. People are like, now I can't sleep. It's like, okay, now we back off a little bit and we kind of adjust a little bit. But sometimes people are experiencing a little bit of irregular bleeding that's lasting for more than 6 months of being on medication, then could be that, oh man, we have to check the lining of the uterus to make sure that it's not becoming a little bit too receptive to estrogen and causing a precancerous disposition of the uterus. So, but
That's
that's the
that's one of the
extreme.
reasons. Yeah, that's one of the reasons I do look at levels. I don't prescribe these medications, but I see a lot of patients coming in with all kinds of combinations of medications. And I do look at the levels because I've seen ridiculously high levels of estradiol or estradiol. I've seen crazy numbers with testosterone, DHEA, sulfate. So I do tend to do the blood work as a routine, especially if someone's on HRT, to track because that's the only way I can determine are you being overdosed and can
Yeah.
we, because you're getting metabolically more sensitive, can we slightly reduce those doses, still have the benefit? The last question I have for you is how do you adjust or what is your discussion? Really, two major things. When women are, and 82% of the women coming into my practice are on some form of thyroid medication. It is ludicrous. But how do you adjust HRT for women on thyroid medication for Hashimoto's or anything else, Hashimoto's being the commonest one, and also for the variety of antidepressants? Because we see so many women on antidepressants, anti-anxiety medications. Saw somebody today that started Abilify, was miserable. All of these new psychoactive medications Georgia Ede speaks quite a bit about them. How do you adjust HRT in the face of psychoactive medications, the antidepressants, anti-anxiety, and then thyroid medication?
Well, so often I have patients that come to see me and they're like, I wasn't depressed or I didn't have thyroid problems. I was in perimenopause, and so and because a lot of times they're on these medicines and then things aren't really making a difference for them, or they have subclinical hypothyroidism, and it's like, okay, well, but it's actually perimenopause. And so sometimes, I mean, I work in the spirit of deprescribing, right? And I think you do too. And so when we use hormone replacement therapy, and then people start to feel a little better, and then maybe they're exercising more and they don't have less of the brain fog, then we work to deprescribe, right? And so we can lower those doses of medications of SSRIs and the antipsychotics and the thyroid medications slowly, and then we recheck thyroid levels and things and to see how they go. And oftentimes it is a misdiagnosis of not those disorders, but actually perimenopause, and they really didn't need it at all.
Right. And I think as you were explaining that, I something hit me, slapped me upside the head. The letters are HRT, and for me, the single most important consideration that I think is lacking in most prescribers' mentality is the middle word. It's hormone replacement. It isn't hormonal therapy. You're replacing what is no longer being produced internally, and the more closely you can match that, both with your replacement plus the lifestyle changes, the healthier and the more even keeled that woman is going to be. So
That's
that
right.
replacement word is so important, and the influences that affect that are what we're talking about. Andrea, this has been, first of all, I'm out of coffee and I'm out of tea, so that representing
I
me.
know. I'm the same. I'm like, I'm done with my water today. I've had too much coffee earlier, so I hear you.
But this has been absolutely fabulous. And one of the words I wrote down here, which I love that you said, and I'm going to steal this from you, is the word guideline care. Because I've been looking for something, because that's something we practice against, but I really like that the word guideline care versus individualized therapy. Um, this has been absolutely brilliant. And I think one of the reasons why you haven't been dogmatic in your answers is for exactly that reason. There are no guidelines. The only guidelines that are there is for you as the individual patient. Let me get to know you and let's figure out a strategy that works for you as an isolated individual, not some generic algorithm.
That's right.
And your and my approach are so similar in that regard. Conscious gynecologist, look in the show notes. for all the ways to access Dr. Salcedo. And I just think she's absolutely brilliant. Scientifically, her knowledge base is as strong as I've ever seen, clinically and humanistically, as somebody that approaches you. That's why we have such a strong relationship.
Yeah.
Every aspect of you just works.
Yeah. Oh, thank you so much. And I have good role models, good role models. And I think you and I will be together at Boca in January. So if you guys want to hear more about it, of all this and really get to the nitty gritty of how to help patients, but also yourself, both lay people and practitioners are invited to the Symposium for Metabolic Health. We have a whole day dedicated to women's health that Dr. Nishida and I are working on together. And so we hope to see you there. It's a great way that we can, develop a relationship and have a consultation together too. So I'm excited. I'm really happy to know you, Rob. It's been a really great, couple of years of just learning from each other, right?
Exactly. And again, we've got more and more practitioners that we can refer to and get opinions from. Even if I'm seeing a patient, I may bounce something off you, or you bounce that off me. So we're developing this network of information providers outside of the system. And what we're hoping for is that this will become the system and the other folks are practicing
All right.
outside of it. But thank you so much. I really,
Thank
really
you.
appreciate this. This has given me a lot of clarity. And I hope that this is of benefit for people who are uncertain or struggling with decision making in the space. Thank you so much.
That's right. Thank you so much.